Uh, Regards to all the viewers. Today, I have taken out this video to make some use of the time available in this lockdown where we are not able to do much surgeries. So I thought that I'll be sharing management of a very, very confusing etiology, pathology in the spine surgery. The thoracolumbar fractures. Thoracolumbar fractures are it's a region which is involved in almost 80% of the spine injuries due to the fact that the thoracic region is fixed by the ribs and the muscles, the intercostal muscles. So it provides a splinting action to the spine. So even if the vertebrae are injured over there, superiorly, inferiorly, and on the sides there are splints which are going to take care of the broken vertebra, and the deformity is not going to be having much chance as compared to when it is happening in the transitional region. So the transitional region is D12, some people say D10, I would say to take it safely, D11 to L2. I call it a transitional region. And almost 90% of the damage in the thoracolumbar fractures happens in this region. So when I was, getting trained myself as a surgeon in my parent institute, I had to make a seminar on thoracolumbar fractures, and I consulted many books. And still, there was so much of confusion. What should be the management? There were so many protocols, there were so many scoring systems, but there was no homogeneity. I mean, you have a homogeneity whenever there's a head injury. If you say in India to a neurosurgeon in America that the GCS is this much, he will be able to understand. But in thoracolumbar fractures, this homogeneity was not there. So despite having a plethora of the cases, in thoracolumbar fractures, almost 80% of the diseases, of the fractures, of the spine injuries, they are happening in this region. If you take all the injuries, for example, 100 spine injuries are there, at least 80, almost on an average, they will be involving this region. But still, there was so much of confusion. This confusion is also compounded by the fact that there are difference of the skill sets of the surgeons. Some surgeons are not very well versed with MISS, MISS way of working the things. Some surgeons don't know the kyphoplasty, and then there are so many differences in the teachings, in the coachings that the neurosurgeon has undergone over the years. Same fracture, you ask one surgeon, he'll be telling you one management. Same fracture, you'll be asking another surgeon, he'll be telling you another management, and so on. We need to develop a homogeneity of the procedures done in a particular case. That said, I would also say that each surgery in thoracolumbar fracture is different, and it has to be customized. The treatment has to be customized. It has to be individualized for a particular case. You cannot have a blanket treatment, or it cannot happen that one surgeon is saying, okay, you do this surgery in this thoracolumbar fractures, and the other surgeon, he'll be telling you the same thing. So the basic thing is that you have to develop all the skills of the operating, whether it is kyphoplasty, whether it is pedicular fixation, whether it is decompression. And I would also say that most of the people should make an effort to get themselves trained in the MISS way of working also in the thoracolumbar fractures. For example, I was very lucky that I got to train under a person, my guru, Dr. Sudhir Dubeji from Medanta, Delhi NCR. I was very lucky that I was trained under a guy who was already doing MISS thoracolumbar corpectomy. I'm sure as per my knowledge, there are not many people throughout the world who are doing MISS thoracolumbar corpectomy. So I was very lucky that in my formative years, I got the exposure of this surgery, and I started doing, thoracolumbar corpectomies. It was trained to me, it was taught to me that, thoracolumbar corpectomies have to be done, from, let us say, D7 to L2. They don't have to go beyond L2, because then the curve of the spine, it changes. It becomes more kyphotic. So the practical training was that I don't have to do it beyond L2, but we have done up till L4 in some spines in which the curvature was not so much of lordotic in the anterior portion. So we were able to do the thoracolumbar corpectomies in that region and still produce a stable construct. But there were cases, in which there was small breakage anteriorly where we did the kyphoplasty. And there were some cases which were just a small fragment was coming out through the, ligament inside the cord, where, if you did the thoracolumbar corpectomy in those cases, it will be an overkill. But you cannot do the kyphoplasty there. If you do the kyphoplasty, the fragment will be pushed inside the cord and the patient will develop the biparesis. He'll be developing the loss of the power in the limbs, paraparesis. So there was a need of a procedure which was somewhere in between kyphoplasty and MISS thoracolumbar corpectomy. So we developed a procedure which we have named as partial thoracolumbar corpectomy. We do it by the transpedicular route, and how we do it, that is what I'm going to tell you. Secondly, there was a vacuum in the protocol what procedure is to be done in the cases of let us say L3, L4, L5. And if you see thoracolumbar corpectomies, if you do it by the MISS method, you have to take almost 70 to 80% of the bone out. You have to take adjacent level of the discs out, and then you have to put a cage inside. And it is expensive. It is not a mean job. It's not an easy job. You have to protect the lower, radical as you are inserting the cage inside. And there are chances that if there is a kyphosis, then the cage will be having non-parallel plates on either side. So the cage will not be fitting there. Secondly, cage can never give you a fulcrum on which you can manipulate the curvature of the spine. I mean, you can manipulate some, but not much. It is a big procedure. It's going to take some 7, 8, 9 hours. There'll be a lot of anesthesia exposure. There'll be a lot of, blood which is going to be lost in this procedure. So there was definitely a vacuum for a procedure that can be done, which is filling this vacuum. So we developed a surgery which we call as partial corpectomy, and I would like to show you how I do it.